Maine AAP Spring Conference Series, and thank you for joining us again. This has been just a fun ride for us. We are really fortunate tonight to have Dr. Lucian Gonzalez talk to us about some issues that I think we're all feeling in the primary care world around mental health and suicide prevention. And Dr. Gonzalez is joining us from Minnesota, the land of all those lakes out there. And he is an assistant professor of psychiatry at the University of Minnesota and a specialist in addiction medicine. And he is the chair of the AAP Committee on Substance Use and Prevention. And he is going to give us a great talk. And Lucian, I'm going to moderate the chat, and you need to just let me know if you prefer to be interrupted, or should we save everything for the end?
I'll tell you that I'm fine with really being interrupted. I'll start sharing when we do this. Interrupted because it really is meant to be conversational. And just so people know, my take on where I'm going to go with this subject isn't so much about, I'm definitely, anybody who's heard me speak before, I don't go through telling you what the literature says and here's a to-do list. It's really more welcome to my brain and recent musings around this stuff, because as people can probably imagine, especially because I spend the bulk of my clinical time with young people with substance use disorders, and particularly opiates. They experience death, some of which is suicide, some of it we don't get to know. The other thing that people may be aware of, and I'll talk about these articles a little bit, is I got pulled in on two fairly recent articles, one related to cannabis use and aspects of suicidality, and the other one opiates. And I actually ended up getting some evilgrams from people who clearly didn't read the cannabis articles. Like, of course you think cannabis causes suicide. I'm like, actually, I didn't say that. But it's a lot of emotionality, which makes sense given what the topic is. So bottom line is I have been thinking a lot about it, and it's really caused me to, I don't know, have some musings that I think are worth sharing. So I hope that what this will end up being more is certainly conversational and discussion, and also a way of thinking about ways of creating some togetherness in how we connect and support each other in this really difficult topic area, if that makes sense. So, like I said, I'm going to touch on areas of substance and safety and its intersection, substances and its intersection with safety and suicide. So there we go. My disclosures are none. I have nothing to disclose, and I'm not going to be talking about off-label anything. Some things that we're going to just touch on and have some discussion about is what we kind of think about risk and protective factors for what I'll call youth suicidality, which I'll end up describing a little bit, like I said, about the intersection between substance use and self-harm. And something that I plug a lot, which I think is critically important, is understanding the importance of exploring substance use and the rest of behavioral health in a clinical and cultural context, including, which I'll get to, is questioning, rethinking, contributing to case formulations. Do not undersell yourself if you're not somebody who spends much time directly in providing psychiatric care. You know kids best. When you have suspicions or questions about what you think might be going on in terms of putting the story together, you're right, and you should be contributing to, like I said, I'd say reworking of what you think is going on in terms of what I call a case formulation. So I'm going to start with a little Captain Obvious. And like I said, feel free, Deb, people can interrupt at any time with questions or commentary to put in the middle of it. But there's a reason that I'm reminding us about preventability. First of all, it just is. Suicide is preventable, right? Technically. And something about the fact of its preventability I've experienced is it makes a young person's suicide that much more devastating in a way, because when suicide occurs, theoretically, there's something that we could have been done to prevent it, right? That's what that means by being preventable. And sometimes in the aftermath, I've certainly had the experience where that gets turned into something should have been done. as if we knew what that something is. And that's very, very difficult. And even though it's a distortion, to think that somehow we have that control, we have that knowledge, there was something that we absolutely could have done, we should have done it, we didn't do it. And so I just want to kind of name that's a space that sometimes we end up in, and to just go easy on ourselves when it does happen, is knowing that just because it's technically preventable doesn't mean that we, and which we'll talk about, is we incompletely understand in that moment, in that slice of time when the suicide actually occurs, we incompletely understand how those factors come together. And I'll talk about a certain modeling of that I've personally found helpful in thinking about my part in helping in this area. And the other thing to note is that even though we're not going to get to zero suicides overnight, and really, let's be realistic, we're not going to get to zero suicides likely ever. But as we learn more, it's important that we are exploring and trying to figure out how to not only recognize, but take advantage of what we know is a risk and preventive factors to do our part in making that number as low as possible. The other thing I want to point out, which I think is important, is that suicide it's actually a low incidence phenomenon. Now, those of us who consider ourselves to be pediatric healers, it's, anything that's non-zero is unacceptable and devastating. And yet when we think about it in terms of the numbers and being able to study it and what to make of things, when people say second leading cause of death, is understanding that the suicide itself is a low incidence event. What's much higher, which we end up seeing a lot more and talking about, is suicidal ideation, whether it's what we call a passive death wish or more intent or thought out plans, actual attempts, as well as what we call non-suicidal self-injury. And so a lot of the research that gets done, which we'll talk about, as we've seen, really, when we say suicidal or suicide, what they end up really studying the most, because it's, like I said, it's less challenging to do, is we're talking about those things that actually ultimately end up being risk factors for subsequent suicide, rather than information about the phenomena of the completed suicide. And so, like I said, it's just keeping that in mind, is it's low incidence, which makes it not impossible, but difficult to study. It's also not incorrect to be looking at things that might mitigate the risk factors. It's just, like I said, to understand the difference between, are we talking about the actual prevention of the suicide itself, or are we talking about risk factors, which, as we know, it commonly works in one direction but not the other, meaning not everybody who has suicidal ideation goes on to commit suicide. So you're trying to figure out over time, how do these things come together to bear for an individual person in terms of ultimately committing suicide. And then I just wanted to use this visual here to kind of frame our understanding. As I like to say, the closer we get to death, those are the people who more often die, right? It's young people don't die. And when they do, in the younger groups, as a lot of people are aware, the ones that are due to, predominantly it's due to preventable causes, whether intentional or unintentional. In the far younger age groups, the more likely cause of a physical medical reason is going to be pediatric cancer. And that's still the one that stays in sort of the top 10 list for even older kids. But it goes down, right? The 0 to 4, there's no suicide. You get older and you get into that adolescent age group, suicides become part of the picture. And then as they get into 15 and older, because now they can drive, and we'll look at that, the unintentional injuries goes up, a big uptick because of motor vehicle crashes. And part of that to make the point of the bulk of what makes up these deaths that just, they don't happen as often as this in this age group. Suicide is a big part of that, but also to say, to help, it's a dramatic event, but to kind of reduce the relative drama when people will say it's second, it's first, it's sort of whatever leading cause of death, is to understand it's in the mix of largely technically preventable things. So it's, and I want to go back for a second, because to look at these numbers too, if we look at 2000 compared to 2019, if we look at the 15 to 24-year-old age group in 2000, there were just over 31,000 overall deaths, not suicide, deaths. And in 2019, it was 29.8. So this number has been, pretty stable. And so also when we took the small portion of those that are suicides, it's really, it takes a while to see if trends are really trends, or if something's an actual difference. It's just difficult to follow that. Then the 1 to 14-year-olds in 2000, there were about 12.4 about thousand deaths. And then it was somewhere around just over 9 in the 1 to 14 age group. So just to understand the numbers that we're talking about, again, any number is like, we want it to be 0, right? But just to understand the difficulty then in studying changes and what to attribute them to, we're really talking about small numbers. So it just makes interpretation of information just more a little more complicated. Not impossible, but complicated. With that, though, I do want to talk about some of what are considered risk factors. And I put suicidality here because a lot of times more information relates to reducing risk for other risk factors. So the suicidal thinking or non-suicidal self-injury, things like that, and not always necessarily suicides themselves, which it's difficult to capture the relationship between mitigation of some of these factors and the actual suicide. But just a reminder of some of them. It's not an exhaustive list, but certainly previous attempts, presence of psychiatric disorders, and the list is many. I will let you know that not short of 4 people were in contact with me. I don't know how it got really across the country that this webinar or really discussion was happening. And it was people who had particular interest in different diagnoses to make sure, are you going to talk about this? Are you going to talk about that? And I'm like, I ended up explaining those are important areas, and yet I'm not going to because I have a particular type of conversation I want us to be able to have. But it's also recognizing that when you guys are in your general settings, in each visit, you're not going to have the capacity, as you know, to screen for every possible, like exhaustively for every possible disorder a kid might have. Suspicion needs to be raised at different times for different things, which I'll talk about with some case examples. But in any event, just to say, yes, presence of psychiatric disorders, particularly depression and a couple others. Certainly a family history of depression or suicide. You can read the rest, and then getting down there, substance use, which has a complicated relationship with suicide attempts and completed suicides. And there's some things that seem to be substance specific, but I will say that because it's one of the ones that's used the most often, alcohol, particularly in adult populations, but certainly where studied in youth, a huge impact, a huge involvement in a lot of completed suicide. So alcohol is certainly one. We pay attention to it a lot for a reason, and it's one of the things I think it distracts our attention sometimes when we get caught up in specific other substance classes and forget one of the more common things that kids and adults use, which is alcohol. And it's, like I said, is a big player here. What do we know to be some protective factors in this suicidality? Good problem solving abilities, right? Not only emotional regulation, but being able to see and work through problems with nonviolent means, strong social connections, both family and friends. You know, as I'm highlighted in red, which you'll get to for a reason, is restricted access to highly lethal means, including things like firearms, certain spiritual beliefs that discourage suicide and support self-preservation, and access to appropriate and effective care. Now, can all of these things be present and a suicide still occur? Yes. So even being able to having interventions or being able to check boxes, there's still no guarantee that a suicide attempt or a suicide won't occur. Just keeping that in mind. And then when we talk about prevention of death, when an attempt actually happens, there are some known interventions, some of which are in place, some which go in and out of being in place. One, or I've put not an exhaustive list here, of building barriers on bridges, either removing guns from homes where at-risk youth are, or otherwise limiting access, minimum drinking age laws, which have been shown throughout the country and throughout different countries that when we reduce, or raise the drinking age, predictably correlates with decreased suicides. Again, there's not direct causation that we can see there, but it's a trend that occurs, and you see it very consistently that when the age is younger, there are more suicides. When that age is bumped up, there are less. And then where appropriate, reducing medication load availability. And why I like to point this out, like I said, is we're not likely to get to a place where we're able to prevent every attempt, but there are known ways in which we can at least reduce the lethality and some of the morbidity that young people will experience when they do attempt. The other thing I want to point out about the firearms, which a lot of people know, is oftentimes, particularly for males who complete suicide, firearms is like a big, more than its fair share of lethal attempts. Want to bring it into the present, which some people think that COVID is over. I know nobody in this room does, but that's how the mask mandate conversations are going. But it has come up, the interest of, well, what about during COVID? What's happening in terms of suicide? And then we'll talk a little bit about substance use. A lot of people, I think myself included, on a per person basis, have seen anecdotally all over the map in terms of how people have done. There was this one study that did show, at least in terms of emergency department visits, there did seem to be an uptake in certain mental health issues, and then again, suicidal ideation and attempts. What are we seeing in terms of the deaths, the actual suicides? So far, the information is incomplete. Death by suicide so far seems to actually have been down in 2020, and that there was already beginning to be a trend, and then it was down again in 2020. What we don't know yet, so some caveats are, we don't know, we don't have details yet for youth, and the picture's not so rosy for communities of color, particularly in certain urban centers in the United States. So it's to be continued. But really, regardless of what the trend state, what you said, Deb, in the beginning is, well, we're seeing this. And so it's trying to understand, like, for your practice, for your catchment area, for your hospital system, whichever, whatever lens that you have, people are definitely seeing differences in the way that their systems are taxed, and that's what's important. More important than anything else is understanding the communities that we live with and serve. So what about substance use? It's been pretty clear. We've got a lot of information in adult populations and especially I think some of the numbers in terms of just alcohol use alone. Clearly, substance use has increased in many ways, including, like I said, alcohol sales, alcohol morbidity, opioid overdose, opioid morbidity. When it comes to kids, we just don't have a lot of information yet. We don't know yet. There was one thing looking at one study looking at reported vaping in certain contexts went down, which was unexpected. A lot of people, I guarantee people here on this call will say, well, not for the people in my practice. So again, it's like there's this big picture overview, and then, okay, but what about my community? What's happening there? But as far as like big sweeping changes, it's just not really clear. It's a little bit more complicated. We don't really know how the sort of COVID context is really influenced substance use overall for kids. And then where does substance use fit within the suicide picture for young people? Like I said, particularly alcohol, historically, largely in looking at adults, it's clear its involvement in both attempted and completed suicides. And then for kids, it's certainly a risk factor. And there's been a lot of questions are left over. We'll talk about more like specific recent articles, but things like the idea of alcohol in particular, knowing that it has disinhibiting properties, both alcohol and benzodiazepines. And so does it make it so that if somebody's already depressed or already set up to be thinking about suicide, does it inhibit them enough to get to the point of actually doing it? There does seem to me, particularly in young people, that when there's multiple ingestants involved, that seems to correlate a lot more with risk in terms of attempts and completed suicides. And then there is a question about if there are things that are specific to different other substances in terms of completed suicide. So this was the article where I got the email evil grams. And some folks may have seen this. It came out, I think it was March, or somewhere around March is when this was released. And I just want to point up a couple of things about it. I mean, it's an interesting paper. I mean, what they did is they looked at Medicaid claims, and this was in Ohio. And looking at, as you can see, I put the brackets around here because this is the title of the paper minus the age 10 to 24. I put that in there just so that you know what age group they looked at. And it was a retrospective cohort study. They looked at these, like I said, the Ohio claims and death certificate data. And what they were looking at actually was all of the people had diagnosis of depression. So it wasn't just all comers with cannabis use disorder. It was kids with depression plus minus. The other thing is they looked at who are given physicians gave the diagnosis of cannabis use disorder. So not just cannabis use, it was whether or not they got the diagnosis. So it's depression plus minus cannabis use disorder. And they looked at different, all-cause mortality, suicide, what we call non-suicidal self-injury. And what they found with that group, with that the presence of cannabis use disorder in the kids with the depression diagnosis, there was an increased occurrence of non-suicidal self-injury, all-cause mortality, both including unintentional overdose and homicide, but not suicide. And it was interesting, weird if you read the paper where they talked about, oftentimes what gets reported is usually just the adjusted numbers, but they talked about unadjusted and adjusted. And with the adjusted numbers, there was no relationship with suicide. Now, that adds to conflicting data, depending on the different types of studies. Some of them have shown some link with suicide attempts and completed suicide. So it depends on which group you look at, for one thing. And the other thing I found interesting here too, when you think about the folks that you see in your practice, most of them don't have cannabis use disorder. What they have is cannabis use. And when you think about, and we'll talk about this a little bit more later, is suicidal ideation can occur, multiple times, can occur in a chronic fashion for some kids. That can be present. You commit suicide, if you complete suicide, it happens, it's done. And it's a moment. And so when you think about what happens with kids, especially, let's say they have a hard breakup, or other things that are just as an acute crisis for them, and they're already depressed, and in that moment they're using cannabis, or they're drinking with their friends, or something is happening. Is there different ways in which that we can think about for kids where substance use can be a factor in that kid's death? And so I find that for me, this is something that's lacking in terms of trying to figure out, how do I think about just cannabis use, particularly the way kids tend to use it, which doesn't most often rise to the level of cannabis use disorder, is how do I interpret this? So a little bit, yes, less useful that way. The other thing is in looking at both non-suicidal self-injury and attempts, not all of them are going to show up at the hospital, because this was facility hospital claims data, is they don't arise, or they don't show up at the ED, they don't show up at the hospital. So you're also going to be missing not only the less severe undiagnosed substance use disorder, but you're also going to be missing a lot of self-harm that isn't captured in claims data. So again, it's just kind of knowing what we're reading, and how it's going to be of use to you, and trying to figure out how to approach this in your practice as a whole in a particular kid. The other thing I'll point out with cannabis use is in most of the studies that have been done, it's pretty clear that what's at play is mostly the presence of depression and not the cannabis use itself. And so there's some interaction there, and the key thing that over time seems to need to occur is actually the existence of depression in these young people. I'm going to switch gears a little bit to opioids. This was a paper from last year where they looked at the Youth Risk Behavior Surveillance Survey. This one from the 2017 year. It was a cross-sectional study, and they just looked at ever reporting non-medical opioid use. So that's not prescribed to you, or using it in a way that wasn't intended to be prescribed for you. And it was associated with every other measure of risk behavior, to which I kind of say, duh, meaning that we kind of know that, that risky behavior is associated with all sorts of other risky behaviors. It doesn't really give you a ton of information. A more recent article, and this is the one that came out, I think this one was in April, that I was also asked to comment on, also from the YRBS a little bit later. They tried to look at the timing, the more recency of use, so current versus ever non-medical opioid use, and looked at, found a significant association with all other suicide risk behaviors compared with ones who had never used opioids before. And they pointed out that particularly for those identifying female and those identifying as, and I put quotes around LGBTQ, and this is just sort of my pronouncement for myself, being part of that alphabet soup that's in there that they sort of lump together, is it's really hard to know. This is where we get to the complexity that's identity. I'm not really sure how useful it is when they just start saying that, well, your group is at risk, as if it's like one homogenous cultural group. So that's why I put quotes around that, and I'll talk about that a little bit more. So this does give us like a tiny bit more of a gleaning in terms of like, is there a difference between whether they're currently using or they ever used? There's something kind of there, maybe, but it's cross-sectional. What's the direction of the relationship? It still doesn't tell you much except to say it's associated with risk, so I'd rather you not do it. Is kind of what I concluded. So that's just me waxing poetic about some of the overall associations between substance use in general in kids and some of the more recent articles. It's sort of a what to do about it, right? You'll notice that I referred before to that there's suicidal ideation, but then there's what about that slice, that moment in time where all these factors come together, where the kid actually has both the desire and the ability, and actually dies by suicide. And so what I find useful, for those who haven't heard of it, there's a psychologist called Thomas Joyner who developed something called the interpersonal psychological theory of suicide, because what he wanted to understand is exactly what are the factors that come together for somebody to actually either end up with a near lethal or actually lethal suicide attempt or suicidal act. And this helps me in kind of thinking about when we think of those sort of known or accepted risk and protective factors, is what's my role in thinking about how these come together in that moment when that act actually occurs. And so I wanted to read a little bit about what he says about. So his theory is based on the belief, and I think we can kind of accept these, is that when we ultimately end up dying by suicide, at that time, we have a desire for it, and we have a sense that we can. And part of it, that means, like the quote that's in there, I'm afraid to die. I'm not afraid to die, sorry. But also means, I put in here, capacity means I have access to a gun. I have access to something else that's readily there. So when the impulse finally comes together, it's there. So capacity is both internal, but also what's available to me. And he said that, there's what he calls a delineated danger zone. There's this sense of being alone and not, having belongingness. I put in there also too, lack of connectedness. Bullying can also end up putting in this place of feeling alone. Having losses. I had one patient we'll talk about who ended up, because the family moved when she was in high school, was immediately separated from the friends that she had the sense of having no friends, was disconnected from her sports. So things that can both contribute to this sense, but also buoy people up. What gets them out of feeling that sense of aloneness? Then there's the burdensomeness. And here I put it as not only knowing that you're not a burden, but knowing what your value is and the things that we can help them connect with, that have them be connected with their sense of value. And that's where I put that list and bolded, particularly in red, raising drinking age and limiting access to things like firearms. Is there are certain things that are not controllable, but certain things that are, in terms of what it contributes to a kid's sense of capacity to be able to do it and actually end up with a completed suicide. So I just wanted to put that out there. That's a way that I make not only some of the literature a little bit more meaningful to me in a clinical setting, but also helps me understand where do I see my role with this kid in terms of enhancing their strengths and decreasing the likelihood that they're going to end up in that situation, still knowing that I can't 100% prevent it. And then I won't spend too much time on this, but I just wanted to talk about my approach basically to every case. And it's not only in terms of how I collect information and how I kind of get my sort of diagnostic thinking together, but it's also what I decide to do in terms of referral. And this is something Pamela Hayes is a psychologist in Alaska, and she put together this mnemonic called addressing, and it's one way of approaching not only identity and culture and its intersectionality for the patient and the family, but also myself and remembering who I am and what I'm bringing to that interaction. And so on it is it's not only these different demarcations, but it's also thinking within the where you're living, which in the United States is which one is relatively more power or less power, right? And so age and generation, disability status, in the case of ethnicity and race, is like anything non-white, less power in the United States, more stigmatized. Sexual orientation would be weighted towards heterosexual, sexual identity, cis, indigenous heritage, et cetera. And so it helps me to, like I said, is to remember, and if I don't know, is not only ask and understand who's in front of me, who I am coming in the room, but what's important to them. So when I'm thinking about, I'm concerned about maybe whether or not there's depression or the impact of an impending divorce or other things, is understanding it in the context of, like I said, not only who they are, but which piece of this is important to them, especially if I'm thinking about referral or how I'm working with them. Because, you know, we might be quickly zero in on something that really that's not what matters to them. It's some other piece. And so it's helping them be seen, which I think is a lot of what can end up contributing to a sense of loneliness and burdensomeness, is that I'm not seen. So the power of being seen, but then also getting their input in terms of, like I said, is the work that we're going to do together, or if I'm going to recommend referring you to somebody, is what does that person need to know? And where do you want to, what do you want them to know about you? What's important, including, are there features of that person's identity that are important? Certain things may matter, certain things may not. It's important to get from the kid. And the other is, I like to point out intergenerational issues. And so, for instance, I think of a patient I recently had who was a Muslim, which to him, what was important about being Muslim wasn't so much about spiritual aspects, it was cultural aspects. The other part that I had to bring into the room was, again, that intergenerational influence and how it played into the relationship with him and the female members of his family, which was important because of the issues that he was having and his relationship with his dad. So in any event, it's a long-winded way of saying this is the way I map every kid onto this as I approach everything with this addressing with an addition. So I have modified to have it to be address A squared addressings, and its appearance. And it can incorporate a number of things. But for one thing that comes up to me, especially in our sort of fat shaming, the war on large bodies, the war on fat, is body shape and size, and remembering that and remembering how kids might experience that. And I'm dealing with that actually in our clinic right now with the residents, because of particularly the atypical antipsychotics that they give people because of metabolic changes and stuff, is I'm, kind of helping them with, yes, we have to talk to them about the metabolic stuff. We have to be very careful about why are not feeling like people are being attacked for the body shape and size, the body that they're in. And the other is I put substance use as separate. And it's particularly, as everybody knows in different ways, it's a stigmatizing thing to have, whether it's a disorder, or you get labeled as a disorder or substance use at all, but there's intersection then with other aspects of identity, particularly race, particularly aspects of gender and other parts of identity. And so that's why I personally add the S. I think that that's an important, like once that's sort of a feature or identified as a feature, that has to go in there, and I have to incorporate how that person then moves through the world and how they may be received and treated in other parts of the system and other parts of their lives. So I just want to talk about a couple of recent stories relative to this before totally opening stuff up. Just two stories. And I have changed the initials. Totally, this is actually based on, TP is based on nicknames. There's a particular psychologist I work with in our department who is a trauma specialist. She does trauma focused CBT, and she started this habit back and forth of we just give little nicknames to the patients that we work on together. So these are not his initials. It's TP. It's based on his nickname we've given him, which is Twin Peaks, which I can explain another time. My point with this one though is racism kills. So this is a now 18-year-old kid. I met him when he was 15, and this quote is from the most recent emergency department visit that he had. He was brought there by his case manager because he was had a fight on the phone with his adoptive parents. That's a complicated story, and was feeling suicidal. So they brought him in, and I was just really livid by this. He allegedly threatened suicide. And this was in the context of how he was characterized. And I'll just read a little bit of it. What they decided was important to put in is a history. List of medical history of, but kicked out of his adoptive parents' home, they placed an order of protection. Chronic behavior concerns, low frustration tolerance. Speaking of parents, he got mad on the phone and was behaviorally and emotionally dysregulated. He broke a TV and was damaging property. His behavior was witnessed, blah, blah, blah. And then it was, he allegedly threatened suicide. Why this matters, I want to tell you a little bit more about him. This occurred 2 days after Daunte Wright's murder. This was in the middle of the Chauvin trial. It was actually the day that the prosecution rested in that trial. And would it surprise you to know, he's biracial and he codes as Black. And the experiences and a lot of the life experiences that he's had stem from being disconnected from his birth parents due to their substance use, and being adopted by the white half of the family that had behaved in a racist fashion towards him throughout his entire life, both overt and subtly, but never subtly to him. And so part of his, sort of just being worked up or dysregulated or whatever it is, if anybody bothered to talk to him, is did anybody recognize who was in front of them and what was currently going on? And so it's just, bottom line is remembering who's in the room. Sometimes it's pretty obvious, but even if it's not, you could ask. Stay aware. And then another one is HB, who is a young patient of mine who I only had the pleasure of knowing for 3 months because she died in February. Met her in December. She had developed a opiate addiction that involved the use of fentanyl. And the quote I have here is, she was very clear with me that I, was worried about aspects of depression, but I needed to use her words because she said, I've been depressed before. It's not depression, it's something different. It was almost this really existential despair, really feeling disconnected. And what she talked about was I only feel connected to that warmth when I'm using. And when she first said this to me, it was actually related to some of the psychedelic experiences that she had. But she also connected this to fentanyl with conversations that she had with her mom. And the hard part about, there's so many hard parts about this case, having a young person who was 19 when she died, is fentanyl is certainly in the end what killed her, fentanyl, but not knowing, and we often don't know this with a lot of opioid deaths, was there an aspect of it in the end that was intentional pushing it over the edge because they were either done because of the experience of addiction, done because depression builded, what factors came together. And you know what, it's what reminds me that the aftermath of the suicide is really is for the living. But at some point, what I hope it does do is inform how we contribute to, like I said, those circles in the Venn diagram of how we contributing to buoying, increasing strengths and decreasing the likelihood that something like this happens. We, of course, still don't know, still don't get to know. For anybody who, because I've had people say that how do we know? And some people don't like the term death of despair because it's not specific. But when it comes to opiates, just about every kid that I've worked with who I've had on buprenorphine, Suboxone for opiate addiction, they've all said that at least one of their overdoses was on purpose. They were not only despairing for their own experience, they felt like a burden to their families. They didn't want them to put them through this anymore. So the idea that a fair number, which we would really never get to know at this point, of opioid overdose deaths are likely to be suicides, or at least in part suicidal. So I'm sure everybody here is now saying, great, Jerk, what is it I'm supposed to do? I think there is a lot of hope. Like I said, one of the things I really like Tom Joyner's modeling, of course, it doesn't account for everything, but it gives me a framework for thinking about, for an individual kid, how am I thinking about pulling these strengths and protective factors together for them. And reminder that to do ask about suicidal thoughts, and encouraging caregivers, parents, to not, first of all, not deny it, and not like sometimes something like, you don't really don't think that way, don't think that. It's actually be curious and do ask about it. So it's not just us, but it's caregivers. Do ask about substance use, and it's part of my my counseling with them. Is I do explain, it's like, I'm not going to sit here and tell you don't ever use drugs, even though it's the healthiest thing for you to do. But this is one of the many things that I worry about, short of addiction, is that what you might end up doing, what somebody else might end up doing during one episode, one occurrence of using. I say always consider substance use in cultural identity and clinical context. And like I said, is I want to empower everybody. I do this myself. I've re-diagnosed kids multiple times, not agreeing with other people's diagnoses. You absolutely have a role in questioning and reworking psychiatric case formulations that kids have. And these are just some suggested readings. This is Joyner's book. And yeah, so that's what I got, just some food for thought in terms of things to read. And it's time to chat.
Lucian, wow. Thank you so much. And I'm going to start the chat with Jen's questions, and then
Okay.
I'm going to lead in because
Okay.
Joyner's thing really has made me think so much about that sick pit in my stomach when I leave the exam rooms, because, well, I'm going to start, Jen, I'm sorry. I'm going to ask your question because, because I hear that from more and more kids. I think their parents are so stressed. They have this real sense that they are a burden. And when I hear that from a child, it always has, I inhale and it always sits there, and I worry about that. And that model has really just put that into context for me. And I try always, when I hear that from a kid, to sort of reformulate it and leave that encounter with some sort of empowering thing, so that kid, but I always feel not successful at it a lot of times too. But I think kids are so tuned into the adult stress. And I'll just throw that out, and then I'm going to ask Jen's question. Sorry, Jen, because that just hit me as so powerful.
I hope to come back to that, because I think there's, yes.
Yes. So Jen, do you want to come off mic? Because your question is really interesting too. Yeah. So Jen talks about.
That's my cat, by the way. She likes croissants. That's what she was doing. Her head was in the bag to eat my breakfast.
We're not allowed to come on video. So
you're not?
No, I'd set up to where it says you cannot start video because the host has stopped it. It may just be for me though.
Okay. It may just be.
So my question is, It sort of stems from, I'm working on a policy statement and a clinical report on the hospitalized adolescent with 2 adolescent docs. I'm a hospital-based pediatrician, and they are definitely saying that hospitalizations for basically all mental health concerns in adolescents and I can start my video now. Adolescents
Yay.
and young adults has definitely increased. And one's in New York City, I'm in Portland, Maine, and one's in Seattle. And so we're actually holding our publication to get some COVID data, like like from kids database or whatever. And so when you were saying the incidence hasn't really gone up, it made me think that that if that's true, then is the problem not that children who are really vulnerable and really sick psychiatrically or with their substance use or eating disorder, whatever it is, there's like a widening, a divide. And if you're really having mental health issues, you're really not doing well and you end up in the hospital. Whereas there's a group of kids who may be doing better at home, but overall the numbers are not that increased. So I was just trying to figure out why I have this bias that things are so much worse right now. And maybe it's just like really bad is really, really bad. And then,
I don't think it's, well, obviously, I mean, we all have a bias, and I mean, to some extent, I think we should. What we're seeing here in Minneapolis is the same.
Okay.
There are bed crises, and pediatrics is freaking out, and they actually put a separate kind of ED unit to board kids. And so this is what I was saying is that, well, sort of so far the big number doesn't look any different, but really for kids, we don't know. And I think that, as we all know, that the problem with these big numbers is it doesn't reflect, okay, but what's like, it's just like I like to say is like, I'm not a test point. And that's the problem, is they're like, it's thanks for that. I need to look at what's actually happening here, and it is what's in front of you. It's like valid on its face. And for me, what I've seen here, like I said, in addition to not being able to get like kids on the units, they've also though reduced beds. They've also for different reasons, different services, like we have the mobile unit that'll go to people's home in the main county, Hennepin, that has Minneapolis. And for a while, it's called COPE. You can call, but they won't come to the house. So like a lot of pieces of the system became non-existent. Yeah. So I think that part of it is each place being able to look at what were the pieces of the system we had, which we all know before COVID hit, stuff was not adequate. Right. And now COVID hit and you're losing pieces, and there's poor interconnectedness. So I think there are system pieces, and there is the phenomenology is who's doing what. What I found, what we found coming into the emergency department, like particularly like most of my patients said, they like dug deep, and I'd say on average we're doing well. A lot of my families, because I do see some kids for like not younger kids, non-substance related stuff, who like, as one of them say, we're used to chaos. It's just what's the chaos this week. So people who are already kind of in the system knew how to navigate it, even though of course you get tired from it, but there's a certain amount of energy that they're used to doing, things that are safety planning, all these other things that what I was seeing, and particularly we see it with adults, because I'm working with the adult residents, it's the people who, this is new, right? They spazzed out, like, what is this? Like, like what they think is a shutdown, which, isn't anywhere near a shutdown, and they're spazzing. So I part of what we're seeing is people who didn't have previous diagnoses, didn't have previous encounters with behavioral health entities. Those were the kids that were showing up more often in the pediatrician's offices, in the urgent care, in our behavioral emergency, things like that. So that's one thing that we've seen. And I'm seeing some nods, like that seems to be at least part what people are seeing. And then who of the kids who already have like struggling, how are they struggling differently? And I think probably some people have read this. It's come up in a bunch of places that we've kind of likened COVID to war situations, other natural disasters and stuff, where there's a coming together, although we feel a lot of division, but we have our peeps. There was a lot of coming together, particularly on the community level, right? And is that's starting to fragment. And so there's this thought that the big wave is in the months, which none of us is calling it post-pandemic, but that's kind of what they're calling it as things start to come together, is people unraveling in a different way. And is that going to look different? And I just think that even though, like I said, all of these little, look at YRBS, look at Monitoring the Future, look at the whatever, look at the hospital data, look at the death statistics, data are, right? They say something, and yet how is that, right? Because it's like you're saying, I'm hearing this doesn't, I'm seeing what I'm seeing, it's real. And so it's just, knowing that you're right, and what are you pulling from to be able to figure out what are the factors involved to figure out what's really happening here and what to plan for.
Yeah, I think you bring up a good point, which is what I wrote and is in the chat is what I actually think. But you're right. I have not looked at all the other factors that have changed because of this, and the going into the home is a fantastic example. I mean, and around here you talk about like bed capacity. We get one patient in a psychiatric hospital, and they're closing like 50 beds because of who has been exposed. And so yeah, I think I was just too concrete about it and not thinking about it broadly enough. So thank you for indulging me.
Well, and I think it is a crisis, right? And I think it's just how everybody's defining it. And I always invite people, especially as I personally get involved a lot more in really deep community engaged work, that where you are better than anybody else does. And so it's the idea of reaching out and figuring out what are the pieces at play here, because that's way more valid than, this is why I did not show 800 Monitoring the Future slides. It's who cares what's going on where you are and what pieces might be at play. So I think it is a crisis. It's just you guys figuring out how are we defining ours, because what we're experiencing is crisis.
Thanks, Deb.
Thanks, Jen. Yeah, she asked a good question, Lucian. Are bridge barriers part of the infrastructure plan?
Oh gosh, I don't know. Does anybody know?
I have no idea. I wonder if somebody that's part of urban planning. Does anybody know that?
That's a great question.
It is a great question.
Yeah, and it makes me think of. It's why I harp on the alcohol thing, not only the drinking age, but there's a good paper that talks about there are basically 9 known on the sort of policy public health level interventions that if every state just did it, we know has huge impact on delaying initiation, limiting negative alcohol related health outcomes and stuff like that. It's just this, well, it's not like stubbornness, cha-ching, where the money is, that we don't just do that. But with something like the bridge stuff, is just it's money. It's not like people making money off the bridge, but it's just we don't want to spend it. You know how they are. It's dumb. It's ridiculous nickel and diming things that could make a huge impact. And we all know this because we're pediatricians. Who is the voice for them? You would think it would be everybody, and as you know, it's not. Their kids are an afterthought.
Well, it's probably better to plan for it at the beginning than
Right. That's how we think. But now I'm gonna that's totally gonna I'm gonna hunt this down, Bridget. Okay. What's in the infrastructure plan? I don't know, and it's a great question.
I'm wondering about alcohol use in adolescents, especially with remote schooling, when some of them have been home by themselves a lot during the day, and what because they've probably had more access to that particular substance.
And again, like I said, is what might end up being pulled together from, I call it the Me Too studies, where people go through and look at data waves from blah blah blah, and I'm like, it matters what you're seeing. that's what that, you know, and finding ways to find that out. Because as you know, some probes get that information and some don't. And it makes
Yeah.
sense to think, okay, who and how. And a lot of it, this is what I wanted to bring up too, is the systems that we created really want to encourage us to not take the time to do this. Because a lot of this is really, as you know, the best we have with kids and families is time. And that's what, like, really a couple of generations before us were part of facilitating us getting to this place where, why don't we have any? Because that's what we need. Pandemic will allow at-risk people to feel that calling a hotline is more valuable since we have all gotten so comfortable with virtual connections. I do wonder that too. And I didn't bring this up because I mean, really, I wanted to limit how much he had to be inside my brain. But there's a guy, I think he's in Seattle, but he's looking at not only the data mining aspects of it, but making use of kids' cell phones in real time, in his case around looking at suicidality and points of potential intervention. But the idea, like you're pointing out, since people are, that's where they are, can we use it in a way that's effective and approachable? I think that, you know, and people are going there, but do we need to go there more? Right? You know, so it's a good point.
I do. All right, it's the top of the hour, you guys. I am gonna say, oh wait, it's always enlightening and pleasure to me. It is. Thank you for a trip into your brain. Lucian, thank you so much. We all really, really, really appreciate it. So much. We love having you in Maine and hope that we can get you here back again in person at some point.
I'll be happy to do that. We'll have to figure it out.
Yeah, when real travel is really a part of life. Thank you so much for joining us.
And thanks all of you for taking this hour.
Thank you so much, Lucian.
Thank you, Lucian.
You bet.
Our pleasure. Thanks, Lucian.
All right. See you soon.
Talk to
Take
you
care.
soon.
Take care.
You bet.
Thanks everyone for joining.
All right.
Have a good night, everyone.
You too. Bye, y'all.